Morning, everyone. To those in the room, welcome, and also those online, give you a very warm welcome. I would like to thank again Magnus and the organising committee for inviting me. And I trust this short talk, I will at least give you a background of what I've been involved in over these many years. What I would say is that the reality of research is that you don't come to a eureka moment immediately. Often it's 99.9% inspiration, or not inspiration, but perspiration, and 0.1% inspiration. And you learn from others. Now, my talk today is on the use of potassium salts in the treatment of dentine sensitivity. So I hope in this short time we can at least explore this subject. I have to disclose that I have a number of patents on bioactive glass formulations and other products. I am a co-founder and director of a company, as well as clinical consultant, and I've had over the many years research grants and support from various companies. The aim of this particular talk is to provide clinicians and researchers with an overview of the use of potassium-containing desensitizing products, such as in toothpaste, mouth rinses, with or without oxalate products, as well as evaluating the efficacy or efficiency in the treatment, both in vitro and in vivo. Now, when we look at mechanisms, actions, you can't see that in the clinic. So a lot of what I'm going to say is based on in vitro and animal, but there are clinical aspects as well. Very quick background. I don't expect you to read all this, but this is simply about where do we get potassium from. It is toxic in high levels, so it has to be carefully controlled when human consumption is involved. Also in the UK, nitrates in the water isn't particularly good. It's found in an impure form. You might remember the old-fashioned term was saltpeter, also niter. And again, it's derived, like both things in life, from Latin salpeter, or salt of the rock. You can find it on some countries, in Egypt, Spain, and Iran, for example, and in caves. There's lots of saltpeter due to the bat dung, if you like, or urine found there. The Chinese discovered mixing nitrate, sulfur, and charcoal was very good for explosives. Fortunately for us, the toothpaste in the concentration we use do not explode. Historically, in the US, to mid-19th century, caves in Kentucky, Tennessee, and West Virginia were extensively mined for saltpeter that was used to manufacture gunpowder. And now it's more based synthetically. Introduction to potassium salts in toothpaste formulations. Robin Orchard and myself did a review over 20 years ago, and we looked at the research published, and what we found that a number of reviewers from the Cochrane, from the US, Kuna Cruz, for example, in the reviews, and a postgraduate student of mine, Karim, looked at this. Some of them were systematic reviews. There are now more meta-analysis on the efficacy of toothpaste, but they questioned the efficacy of the products, not the products themselves, but whether potassium actually was the main ingredient. And we'll discuss this as we move on from the talk. The mechanism of action is either by tubular occlusion or nerve desensitization. And potassium ions have been reported to work based on historical animal studies by nerve desensitization and not by tubular occlusion. But if you mix potassium with oxalate, for example, it is supposed that you get a dual action, both of nerve desensitization, i.e. from potassium, and oxalate as a tubular occludant. And potassium oxalate has been reformulated as a mouthwash from the original David Pashley patent, and both in vitro and vivo studies have indicated that the product acts as a tubular occlusion in reducing sensitivity. And Sharma in India is one, and some others, one from Greece and from America. And more recently, and this has been looked at our university, potassium-releasing bioactive glasses have been developed subsequently and may offer relief for dentine sensitivity in toothpaste formulations, and also potentially in composites. For those of you who are clinicians, dentine sensitivity, hypersensitivity, is relatively common, yet troublesome clinical condition that may impact on the quality of life of individuals. Pain is described as rapid in onset, sharp in character, and transient duration. And several surveys going back from Canadian surveys to the present suggest that clinicians often struggle to identify patients with dentine sensitivity, which may in turn lead to the underestimation of the true prevalence of the condition. There have been a number of theories of pain transmission across dentine. When we talk about pain transmission, pain doesn't actually transmit in the sense, it's the stimuli which transmits. And historically, there was direct stimulation of nerve endings in dentine. The odontoblack transduction theory, hydrodynamic theory, direct ionic diffusion theory, which really is a modification of the hydrodynamic theory, and lesser-sense piezoelectric theory and streaming potentials. This simple cartoon of diagrams simply shows that where there's exposed dentine in the cervical area, you need open tubules as well as exposed dentine, and these tubules need to expand in order for the stimuli to impact on the dentinal fluid. So either through, as I've already said, through occlusion or reduction in nerve excitability. And for those trying to remember our basic physiology, this is a diagram here of the innervation, and we get this action potential. And then if you apply something like potassium, you get a decrease in activity and therefore no action potential. And according to the Pashley group, minute rapid movements activate the receptors in the pulp, and these are generally alpha, beta, or A delta fibers, but not C fibers. C fibers are historically considered to be more direct pain, as we would understand in dental caries. Now, the main theory is the hydrodynamic theory, but originally it was the odontoblastic transducer theory was discounted because of historical, I suppose, observations. And with more modern investigations, this has come back again. And so it does appear that there is a major role for the odontoblast, but people are not quite sure whether we can prove this clinically at the moment. But we've now identified, not me personally, but groups, that the odontoblasts express mechanical and thermosensitive transient receptor potential ion channels. And there's a various group of these. And it says that these may be sensitive to the potassium. And so you get external stimuli called dentinal fluid movements within the tubule, and or odontoblast and or nerve complexes respond, may represent a unique mechanosensory system with odontoblasts acting as sensory cells. And according to El Karim, in 2011, the new evidence might suggest that odontoblast acts as a sensory receptor for stimuli. Now, this is a table of the TRP channels from one of my postgraduate students who's a PhD. I'm pleased to acknowledge that he has successfully passed his degree despite his supervisors, which often happens. And he has identified through the research literature he did the various types of channels. I just want to move on to the hydrodynamic theory. And this is the theory that we use on the basis of management. And this is basically fluid movement within the exposed tubules. And the fluid should obey principles of fluid movement through capillary tubes. Any increase in functional radius of dentinal tubules should greatly reduce the rate of fluid flow, thus reducing dentinal sensitivity. So this is the theory, we accept it, but it's not, to my mind, it's not it can't explain everything. I think that's probably true. Now, one of the issues when we do research for in vitro, we don't use cervical dentine because it's very difficult to actually section and cut the cervical area. We use mid-coronal dentine, and they show nice straight capillary tubes, which is not the case, as those of you who understand the anatomy of the root. And so it's very idealized, and often the criticism made of the disc that we use of mid-coronal, it doesn't relate to clinical experience. But having said that, it works fairly effectively for our purposes. Now, Hodish in 1974 was the first investigator to report that potassium nitrate was a superior desensitizer. However, a number of investigators criticized the controls of these experiments, and they also stated that the conditions that Hodish used were unrealistic and does not accurately represent the in vivo application of potassium. Hodish used supersaturated solutions of potassium nitrate, which we wouldn't normally use in commercial use, which is about 5% in toothpaste, 3% in mouthwashes. And one of the issues, if we accept the potassium ion theory, is that how do you replenish the amount of potassium to create the, if you like, the imbalance with the potassium sodium pump? And this has always been an issue. If we look at the evidence for clinical trials, the classic one here on your left, very clever marketing. This is from Denko, the original toothpaste in the US, and they use soda fountain straws to show the difference of improvement between potassium nitrate and the market leader at that time, strontium chloride. On the other graph, you see that there was an 8-day study, 3 groups. I don't know which group is which, but you can see over 8 days there was a reduction in 2 of the groups. I presume from the green bar that that must have been the placebo. I would hope it would be the placebo rather than an active group. So if we look at this modification of hydrodynamic theory, which really direct diffusion of potassium salts, it was based on animal experiments, the cat model, because one of the problems is that although potassium nitrate was effective in clinical practice, when Pashley looked in the lab, it didn't include the tubules. Now, most toothpaste contain silica, which in part would include the tubules, but potassium per se didn't include the tubules. So Kim and others, Kim and Markovich in Penn University, took an animal, a cat model, cut a cavity and wired the poor cat up, and found that potassium caused depolarization of the membrane of the nerve. And that was enabled that they prevented the action potential occurring for a very short period of time. Now, the molar solutions that Kim and his group used were very high, and the cut cavity meant that the dentine was cut to almost close to the pulp. So it wasn't the same model, if you like, as we have in the clinic. And so it virtually was direct ionic diffusion, and the potassium ions were seen to be the most effective. And as I mentioned, the Pashley's group didn't show any evidence that it blocked the tubules. So Kim and Markovitz's group, I think Bellotto was one of their researchers as well, in the 80s, suggested potassium salts may work by increasing the concentration of potassium ions outside the nerve, extracellular concentration in deep dentine. One of the problems with the earlier Kim work, it didn't mention the change in potassium ion concentration on the other side of the dentine disc. This paved way to a new hypothesis, which I put in my thesis when I did my doctorate, a direct diffusion of ions as a mediator for dental pain. Criticism of Kim's work: the animal model has been previously criticized as being dissimilar to conditions associated in humans by Senna, who was in the block drug group. Senna stated that, as I've already said, Kim used deep cut cavity preparations, and there's only a thin slice of dentine between the exposed dentine surface and the pulp, and it was a very short period distance that potassium ion had to go, which is again an issue when you see the length of the tubule in real life. Now, if we apply potassium salts directly onto the tooth, historically, like potassium chloride, it showed that it didn't work. If potassium worked, you would get an initial pain and then a depolarization. And to my mind, in the literature, that hasn't been shown. And the other issue, that if, according to the hydrodynamic theory, that the outward flow may actually prevent the diffusion of ions near the pulp. Now, Steed, who worked for Unilever, a UK-based, Dutch UK-based company, in the 90s, attempted to provide a mathematical framework based on how potassium may work in a clinical environment. And what he did, he put all the known parameters of the dentine fluid, constant, the distance, diffusion rate, and so on. And he postulated a 1-minute application of 5% potassium oxalate increase potassium around the inner end of the tube for 20 to 30 minutes. Now, when he presented this, a number of us said to him, well, look, most patients don't brush their teeth for a minute. So how would you expect the fact that you wouldn't be able to brush one tooth for a minute if you think how long that would take? So it was impractical from that point of view. But what he did show mathematically, there could be a transient effect. One of the issues that this diffusion of tubule with increasing diameters, but again, as I've already intimated, the dentinal fluid in the cervical region does not always follow the same path to the pulp, not these lovely straight capillary tubes, which Brandstrom suggested they're more wavy. Now, Steed's group in his mathematical model suggested that the fluid was dependent on the concentration of potassium in the mouth, the velocity of the tubular fluid, the permeability of the barrier between the pulp and tubule. And as I've already said, and it's been backed up by others, that a 5% potassium may result in a transient effect. And without going too much because of time, with this slide, but a number of other investigators have also shown this. Now, the Matthews group looked at work in replicating the cat model in a human. They cut a class 2 cavity. They wired the students up. And they showed that there was a transient effect of potassium following the type of model that Markovich and Kim did in their cat model. And what Matthews did suggest, it may not necessarily be a hydrodynamic response. So I think the issue is that when we look at the mechanics of action, is that the potassium story is not clear cut. It's quite clear that potassium contained toothpaste may have an impact, but potassium per se doesn't. Now, with more modern research, it could well be that potassium ion may impact on sensitive channels, and that's to be, I think, determined. But at the moment, to my understanding, I don't think that's been shown clinically. Now, in order to get around this, McCormack and Davies suggested the concept of a secondary messenger nitric acid, based on that there's nitric oxide, I should say, as a secondary messenger. Nitrous oxide is found in mussels and in the pulp. But again, while they suggested this model, it's interesting, there's not a lot of evidence clinically. This is one of the systematic reviews. This is the Cochrane study, and I simply draw your attention to the conclusions, again showing there's no clear evidence for the potassium containing toothpaste for dentine hypersensitivity. The one, Orchardson and Gillam, again, we struggle to find the mechanism, how clear it was. Please don't read all this. These are the various studies we looked at, going from the earlier Tarbit studies in the States, and you can see at your leisure, there's varying results of efficacy. One of the things we did find and others find is a very strong placebo effect on these studies because of the sensitivity issue. Okay, so again, this is a reduction in subjective pain ratings, and you can see again, I did point out the changes of placebo, and one of the problems in these studies is trying to reduce this placebo effect. When I say placebo effect, it could also be things like ortho effect, being in the study, willing to please the investigator and the like. This is from my postgrad Kareem. And again, we showed in 2013 similar results from previous studies. And one of the problems when you look at the any topic in a systematic review, you set the questions. So, for example, if we set the question, we're only going to look at 6-week studies, then you exclude a number of studies which are under 6 weeks. Now, other systematic reviews include those earlier studies, like a week and 4 weeks, and you may get a different response. But we followed the Cochrane guidelines. And again, this is a similar one, and they concluded that toothpaste containing various ingredients do work, but again, apart from the strontium and ACP products. Now, again, it's how you formulate the question in the systematic review that you do or meta-analysis. And Martins et al. 2020 found a similar result. So very quickly look at potassium oxalates, going back from the original Pashley patent in the 70s. Some of you might remember potassium oxalate in sealants by Pashley. I think over the decades, they've shown evidence, and what is shown in literature is the fact that the oxalates are effective. The patent for Pashley's work went out in, I think, early 200s, around about 2013, I think. And so Johnson took over the patent and made it a potassium oxalate mouthwash. Now, Kuna Cruz did a study on all types of oxalate products, including sealants and the like, and came up with a view, apart from the original Pashley 2% model, it currently does not support the recommendation of oxalate. But again, there's been a new interest in this. I did a presentation on behalf of an Indian company, and we looked at management options for sensitivity. Potassium ions decrease, as I said, the excitability of nerves at the base of otic processes, reducing tooth sensitivity. Blockage of the fluid may be due to calcium oxalate products within the dentinal tubules from the potassium oxalate. And again, at the moment, the management and dentine sensitivity is not well established. So this is a study from Elides and group when they split up the two groups, as you can see, and there were toothpaste slurries. They couldn't find any intratubular extension of the surface precipitants, but they found with 1.4% potassium oxalate that crystals did expand into the tubules at very less than 20 mu. And it did reduce the fluid flow in the studies they did. This is a similar study by Sharma in India, and they showed after 12 treatments with a control, there was no surface or intratubular occlusion. After 12 treatments with potassium oxalate, there was surface and tubular occlusion by calcium oxalate. And you can see that from the various studies from open tubules that there was precipitates within 9 rinses. Zia, which was one of my students, we looked at 3 oxalate containing products, the potassium oxalate, which was the Johnson & Johnson, a 3% solution in oxalate containing herbal toothpaste, I think from the Himalaya company. And we looked at the hydraulic conductance, and we did find that the oxalate reduced the fluid flow up to 65% in comparison to the control, which was less than 21%. One of the problems when you do dentinal discs with fluid flow, it's very difficult because each disc is its own control in one way, and the variation of fluid flow rates through the discs often reduces the impact of statistics. And what most people do now, companies and independent researchers, they run a whole load of discs first, and then they evaluate the range, and then they reduce the range, choosing those discs which give a moderate flow through. If it's too high or too low, then that will complicate the results. And what we found was that this was only a master's project, short master's product, but he did find with this mouth rinse, it was compatible with the previous studies. What we did find, however, in comparison to the product that was used by Sharma, which took up to 9 to 12 rinses, our formulation, which is not commercial, it was made up in the laboratory, did it in one rinse, which was similar to the original Pashley sealant, which was very, very effective within one application. So this is basically his results, showing that the oxalate products were effective. These are the EDX analysis of the various groups that were used, and the oxalate comes up fairly well. And this is the results from the fluid flow. And again, you can see that the oxalate mouthwashes are fairly consistent with compared to artificial saliva on the disc. And when we applied the acid challenge, again, there was there was still enough precipitant there to reduce the fluid flow. Didn't eliminate fluid flow, but it reduced it. And that's something we have to look at. A lot of studies don't use an acid challenge. And the thing with an acid challenge is that if it's just surface product, precipitant, that could be dissolved through the acid. So what we want to do clinically is to have a toothpaste or a mouth rinse or whatever that resists the acidic challenges that we experience. This is from a Lynch study in the States, and again, showing that their reduction using their 1.4%. And the conclusion from this study is that rinses containing 1.5 to 2% do not consistently demonstrate a benefit over placebo in relieving dentine hypersensitivity over 8-week use. Now, Burnett group, they were from GlaxoSmithKline, now Hainan, and they did 3 consecutive studies using similar patients. And what this result suggested that they got different results from each of these studies. To my mind, I don't have a problem with this because I would challenge any study that claims that everything works in every study. If you remember, we're looking at subjective evaluation, and you often find that it's very difficult to get positive results in every study. So I don't have issues with that. Now, the interesting thing is that some of the examiners in this study were similar to the ones that were used in one of the Lynch study. So the Milliman, again from the US, showed there was a significant impact. So this is a problem that we face when we look at these studies. You could have a very experienced examiner, but you don't always get the same results. And that is a frustration in this topic. If you look at the oxalate safety profile for the various studies, there's very few serious, there's no serious adverse events. And in these studies, they did have some transient issues with the exfoliation. What I've found with personal experience, if you have any oxalate or bioactive glass, which is in the tissues, that can cause a tissue response. But generally speaking, there are very little safety issues. Now, historically in the UK, they were very concerned about potassium nitrate being because of the water supply. So they used historically potassium chloride, whereas in the US, potassium nitrate was used. This is from the Burnett group. Now, more recently, in our group, Tiscaya was a PhD student. Again, I'm happy to report that she passed her thesis and is now active in other research. So with the formulation that we patented, we've been looking at various bioactive glasses. We can put potassium, stannous, and all different types of ingredient and fluoride in these glasses. And the idea is that because of its nature, it provides a slow release of fluoride and other ions. So it's almost a very good diffuser over time. So if you look at, say, a fluoride toothpaste within the first hour, if you like, most of the fluoride is gone. Whereas if you have a slow releasing device in a glass, then it will release and keep a reasonable level over a longer period. And we have shown in a lab up to about 12 hours. And we're still looking at this. And with this potassium release, we think that it could result in nerve deactivation when used in toothpaste. The other thing, as you can probably see from the schematic, is that the problem with the composites is leakage and second carriage. And we are looking at least people within the group are looking at the potential for putting it in composite. Got a few more minutes left, I think. Let's briefly go over to clinical. This is from a UK guidelines conference, and we basically decided on 3 groups of people with sensitivity. Those with clean mouths, those with perio-treated or post-surgical, and with tooth wear. Tooth wear and erosion are becoming more and more in vogue, and so it's almost shifted from sensitivity to erosion. But reality, erosion is a factor which is involved in dentine sensitivity anyway. But be aware that dentine sensitivity can affect any surface of the tooth. Now, this is a schematic, a flow diagram, and a diagnosis is key, and differential diagnosis. Now, what I would suggest, because of time, is that we have 2 types of patient. We have a patient we have in our practice for years, so we know about them, we know what the type of treatment they have, we know their medical, dental, and social history, and the like. And so if they come back a week after scaling or debriding with pain, you can reasonably suggest that that's a problem, or a restoration after a couple of weeks, or bleaching sensitivity following your bleaching. So that's a different scenario to a new patient where you have none of these issues, and you have to spend more time with it. And I think this is an important distinction to make. The key thing about diagnosis of dentine hypersensitivity, by definition, is a diagnosis of exclusion. That means we have to eliminate everything else. This is from ISAR. I can assure you many more. And it's looking at clinicians, what they use. And when you look at the literature, there's no obvious agreement. For home use, again, there's going for oral hygiene is key. Education is key. It's no use giving a toothpaste or a sealant or a root coverage technique if we don't resolve the problems that caused it in the first place. And this is important. You can use all sites of toothpaste. I'm not dictating which one you can use, but these are the ones that have been used in the literature, and more recently the silver diamine fluoride, STF, is, I think, been approved for use in the States for sensitivity. Treatment plan, screening, identification, and depending on the what you found in diagnostic, if it's mild to moderate, you can use, and it's generalized, you can use a toothpaste or a mouth rinse, plus eliminating etiological factors and the like. If it then persists, then you go onto a high level where it be made more invasive. And obviously, if it persists again, you may have to do even more intervention that may be cavities. So this is based on the WHO pain ladder, but it's an early form of minimal invasive dentistry. If it's a localized severe tooth problem, then you can use more professionally applied. So the take-home message is, I hope I provided an overview of potassium salts in dentistry in relation to dentine sensitivity. I've tried to gently guide you through the mechanisms, provide some evidence of potassium salts in the treatment of sensitivity, and hopefully informed you of how to treat. Now, what I always say in these type of talks, what I am not saying you must use this in a way that is very didactic. You should use some of the guidelines which may relate to your practice. and that way it'd be more likely to be accepted. Well, thank you much for your attention. I hope I've kept to time. Thank you.